We've had an eye on staff illnesses, and that's come close to being a pressure point. But in other respects, in terms of testing supplies, in terms of PPE, things like that, those have not been the bottlenecks. And so those arms of the Resurgence Plan we haven't had to activate.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
This week on First Case, we speak with Dr. Christopher Turner, Director of Perioperative Services at UW Health. Dr. Turner is an experienced Director of Perioperative Services with a demonstrated history of working in the clinical arena and hospital administration. Dr. Turner is skilled in healthcare information technology, clinical research, medical education, anesthesia, neuroanesthesia, and hospital operations with an MBA from San Diego State University. Dr. Turner is experienced in team-based management and has responsibility for the daily operations and long-term planning and strategy for approximately 70 operating rooms and non-operating room suites, providing 43,000 anesthetics each year. His experience includes budgeting, operational and capital, metric development and maintenance, report and dashboard development and deployment, service line management, and Epic Optime anesthesia development. And Jeremy, today, I know that there have been many podcasts on COVID-19, but we're going to be talking about a specific experience of a perioperative services leader at UW Health. And I'm interested to get Dr. Turner's perspective, not only current state, but over the course of the last several months and the changes that have gone on, not only in strategy, but in how they dealt with changing that strategy.
Yeah, Justin, I think it's really interesting the way that the operating room has morphed throughout the pandemic. Originally, we started by shutting the entire operating rooms down and canceling all elective surgeries. And then we morphed into a situation where we had a whole lot of backlogs that we were trying to deal with and staff working additional hours to try to deal with those backlogs. And now we find ourselves in a situation as the numbers have come back up in being more selective in the cases that we're doing so that we don't occupy hospital beds. So I'm interested to speak with him about the leadership style through all this change and how he has managed the operating room through this many changes that have occurred over the last 11 months.
That's a great point, Jeremy. It seems like everyone has been pulled from one extreme to another in search of finding some balance. And I hope that we'll have that conversation today. We're going to be right back after a short break with Dr. Chris Turner, Director of Perioperative Services at UW Health.
You're listening to the First Case podcast.
Joining us now is Dr. Chris Turner, Director of Perioperative Services at UW Health. And Dr. Turner, I just want to thank you so much for coming on the show today to talk about a topic that has definitely been discussed in great detail, but I'm interested to hear about your perspectives in managing surgical volumes and all the other COVID considerations and really the process that you've gone through over the past year. So thank you so much for coming on the show today.
No, thank you very much for having me.
All right, so let's talk a little bit about your background. Just introduce the audience to your experiences. And one thing that a mutual acquaintance of ours, Dr. Peter Nickel, said was that you have a military background that has really played a strong part in everything that you've brought to the table during the pandemic. So could you also talk a little in depth on that as well?
Sure. In a nutshell, I am a undergrad from Purdue, did my graduate work in pharmacology at Wisconsin many moons ago, then joined the Navy, went to medical school in the Navy at the Uniformed Services University, and spent 13 years out in San Diego doing my internship and anesthesiology residency with a year diversion to the Mayo Clinic for a neuroanesthesiology fellowship. Left the Navy in 2000, went to the University of Michigan for 10 years, was faculty there. Then left that to change pace, if you will, and went to a community hospital up in northern Wisconsin and ran an anesthesiology department up there before an opportunity came to return to Madison, which my wife instructed me I was going to take. And so we came back to Madison about 6 years ago, where I took the Director of Perioperative Services role at University Hospital.
So obviously we're living in pretty unprecedented times. Can you talk to us maybe at a really high level before we take a deeper dive into the weeds on the conversation? But what is your general role in overseeing the strategy around COVID-19 for all of the operating rooms throughout the UW Health system?
So UW Health operating rooms are managed on a triad system. So we have 7 different surgical sites, and each site has a triad that runs the operating room at that site. And the triads consist of an OR charge nurse, an anesthesiologist, and a surgeon. Each of the 7 sites runs based on that triad model, and I, with my surgical and nursing cohort, have run the operating rooms at University Hospital since I came down here 6 years ago. With the onset of COVID-19 last spring, the system quickly identified that they needed a coordinated response in managing both surgical and procedural volumes based upon the conditions on the ground, if you will. And the 3 of us who were the triad at University Hospital were asked to create and lead the surgical and procedural services work group. The task of that work group is to monitor surgical and procedural activity across the system, to monitor possible bottlenecks across the system, and to make recommendations to the Health Incident Command System regarding what surgical and procedural activity should be ongoing based upon current conditions. We're tasked with doing a balancing act of providing essential care versus providing adequate COVID care. And then we're also sort of tangentially responsible for surgical and procedural policy and workflows related to COVID, and making sure that surgical policy coordinates with the rest of the system so we're not siloed.
So, Dr. Turner, you mentioned that you're assessing the situation on the ground, and I know that throughout the pandemic, it has changed quite a bit from one season to the next. And I'm curious as to how do you make the decision? There are facilities that have made the decision to go forward with elective procedures, and then 3 months later, we've had to scale back and reduce those elective procedures. What goes into those decisions? How are those decisions made at your facility?
Well, it might be worth diverting just a little bit to talk about last spring and what we faced last spring, because that really, getting through last spring informed what we have done ever since. And we're so wrapped up in the day-to-day getting the work done and dealing with the crises that I think we often lose sight of where we started. So if I can take us back to late February, early March of this year, we had just started to see some COVID appear in Wisconsin. Some of my colleagues may ping me on this, but we were very unprepared. So in terms of PPE, we had a plethora of N95 masks because we'd squirreled them away after Ebola a few years back. But that was it. We had 8 PAPRs for the entire system. We had no face shields. We had only the sterile gowns or the impermeable gowns that we needed for day-to-day infection control cases, things like that. We had no negative flow operating rooms. We had very few respiratory isolation rooms. We had no critical care beds really to speak of that were capable of caring for COVID patients. We had enough critical care ventilators for the day-to-day use, but certainly not enough for a surge. And basically, the entire system was unprepared for the kind of surge that we were seeing in New York in particular at the time. It's important to remember, we tend to forget it now, but it's important to remember that last spring, we essentially had no testing capability. So our ability to test a patient or a provider consisted of sending them to one of the very few state centers, having them test the patient, and then we would get the results back in a week or so. And they had very few tests that they could do. One of the massive changes from last spring to current state is now we have rapid, reliable tests that can be done in-house in bulk. And so we can do repeat testing. We can do sequential testing. We can test for antibodies. We can test far greater. At the time that this hit us, we couldn't test. And that's a critical difference. Then on top of that, the CDC came out, and I forget the exact date, but it was in that same time frame that the CDC came out and basically instructed hospitals to stop all elective surgery. We had a situation where we were just unprepared for what we thought was going to be a massive surge that was going to overwhelm the institution. So we shut down. We shut down basically everything. What we were doing at the time was life or limb surgery and not much else. We weren't doing any outpatient surgery to speak of. We had cut back considerably on our operating room staff and had repositioned our anesthesia providers to critical care and to critical care strike teams. We'd repositioned operating room nurses to employee health, to greeting teams at the entrances to the hospital. My analogy for this place is the battleship Wisconsin, which is very big and very impressive and very good at steaming straight, but doesn't turn all that well. Well, I had to eat my words because we essentially, over the course of 3 to 4 weeks, completely reconfigured this hospital from a standard academic quaternary care medical center into a COVID critical care hospital, starting almost from scratch. The kinds of things that we were dealing with then and the kind of constraints that we were dealing with then really taught us in very short order what we had to have in order to provide care in the middle of ongoing COVID.
So as you've seen that shift, that surge that we were expecting in March or April of last year, and we're now seeing that those surges, how has that affected the decision-making process for elective procedures and operating room flow?
Our decision tree, if you will, is based upon the pressure point or the bottleneck that is most prevalent to us. So now we have a COVID dashboard. It's a very elaborate dashboard. And in it, we keep daily track of how many COVID ICU beds are being used, how many COVID general care beds are being used, how many non-COVID beds are being used, what the incidence and prevalence of COVID is in the state and the region and Dane County, what our staff illness rates are, what our staff COVID rates are, what our PPE supplies are, what our testing supplies are, how EVS is doing, how Repro is doing. So we very early on constructed this dashboard, and this dashboard tells us where we are getting into trouble. And then over the course of the summer, we spent a long time, things were fairly quiet over the summer, and we essentially got back to near normal procedural and surgical volumes. But we used that time to construct what we call a Resurgence Plan. So when COVID came back, as we anticipated that it would, we have a different response programmed based upon what the pressure point is. So if testing supplies were the pressure point, we would respond one way. If staff illnesses were the pressure point, we would respond another way. And what we have found this fall is the pressure points really have been inpatient beds, and both inpatient critical care beds and inpatient general care beds. And so our COVID response this fall has been specifically targeted to maintain essential services while minimizing our demand for inpatient beds. And that's really what we've focused on. We've had an eye on staff illnesses, and that's come close to being a pressure point. But in other respects, in terms of testing supplies, in terms of PPE, things like that, those have not been the bottlenecks. And so those arms of the Resurgence Plan we haven't had to activate.
Dr. Turner, it's interesting because as we were preparing for the interview, you talked about modulating surgical volumes. And I hear that that's kind of what you're already talking about here. But I'd almost say, too, did you also make adjustments to the type of procedures? Since you said one of the key triggers was how many hospital beds were available, what your inpatient volume was like. But did you continue to do a lot more of the day surgeries where you knew the risk of needing those beds was low?
Yes, absolutely. So as opposed to last spring where we just shut down everything, this fall we have kept outpatient surgery going, if anything, slightly above our normal. We have taken some procedures that would normally be outpatient short stay and have converted them to outpatient procedures. Any inpatient procedure we have expedited so that their care can be completed and they can be discharged sooner. And the modulation that we've done has been for surgeries that require a new inpatient bed. And those are the surgeries that we have targeted for reduction in order to generate inpatient beds for COVID care.
When you talked about you shut down cases earlier in the year last year, and then when you came to the fall, you picked up more and cases were moving along. Can you talk about the process that you went through for working your way through the backlog of cases that you had? How did y'all decide which cases you were going to do or prioritize the surgical cases in your backlog?
Yeah, so the procedures we used for analyzing and tiering the backlog last summer are the same procedures that we're using to deal with our smaller backlog that we have currently. So any procedure that was seen in a surgical clinic, in the ED, wherever, that needed to come to surgery but was deemed appropriate for postponing, that gets entered into our EPIC record. as a surgical case, but without a date for surgery. So it's in the system. We can query it. We can do data analysis on it. What we added last spring to those surgical bookings was a tier. So we tiered cases tier 1 through tier 4. And tier 1 was a case that had to get done regardless. Tier 2 could be delayed 2 to 4 weeks. Tier 3, somewhat longer, and I think tier 4 was beyond 6 months. So the tiering was built into the surgical case booking. So we can at any time query what our backlog is, who the surgeons are that are most responsible for those backlogs, what surgical departments they are, and how acute those cases are, meaning when we can get to the backlog, which are the ones that need to be dealt with first. And over the course of the summer, that was how we drew down the backlog, by focusing on those cases that were highest tier and focusing on those services that had the biggest backlogs.
I've been all over the country throughout this pandemic surveying hospitals, and I don't think I've seen that approach. So it's a very interesting approach. I'm curious, one thing that hospitals do struggle with is the higher risk portions of the surgical procedure. And I've seen variations throughout the country of how organizations are handling the higher risk portions, such as intubation and extubation, where you have greater risk of aerosolization. Can you talk to us a little bit about what you guys do there at UW, as well as maybe what hospitals that don't have the resources could do to eliminate the risk during those times?
Yeah, and I should lead off by absolutely acknowledging that this is a moving target, that our recommendations for our own people have changed multiple times. And I have to acknowledge that the fact that the guidance keeps changing adds significantly to the burden on the frontline folks. I get asked with some frequency, okay, what's the direction today? What are we supposed to do today? And I gotta admit, they're right. Early last spring, the American Society of Anesthesiologists, among other surgical societies, came out with guidance for so-called aerosol generating procedures. And in the anesthesia world, this is primarily intubation and extubation, placing and removal of endotracheal tubes. Because we didn't have a lot of experience with it, and because there was a lot of unknown about COVID in terms of, mechanisms of transmission and infectivity and things like that. If I recall correctly, the original recommendation was that any patient who was intubated or extubated was supposed to be done under, if not negative flow conditions, at least with N95 and face shields and full gown and glove and the whole 9 yards. That posed huge problems at the time, more so even for other places than for us, because there was an ongoing shortage of personal protective equipment. So it's difficult to adhere to stringent guidelines when you don't have the supplies to do it. So there was a lot of angst. There was a lot of concern on the part of the providers, a lot of uncertainty as to what the best way to handle cases were. And it's taken us quite a while to sort of work through what really is appropriate PPE, what is appropriate use of negative flow spaces, what is appropriate use of respiratory isolation. And this, of course, doesn't occur in a vacuum. So the ASA has modulated their guidelines. CDC has changed their guidelines. Our internal infection control has changed. And hence the frontline folks' frustration with changing procedures. But nevertheless, what we're doing now is easier and more reasonable than what we started out with 9 months ago. So really the two variables that we are most concerned about is the patient positive or not? And if they were positive, when did they turn positive? So we have one set of workflow for a patient who's been positive for 1 to 20 days, and another set of workflows for a patient who's been positive from 21 to 90 days. And then the other question is, what is the risk of the procedure? So intubation and extubation are high-risk procedures, but endonasal neurosurgical cases, are included in that group. Facial trauma, respiratory tract surgery, esophageal surgery, things like that, where the surgeon's face is right in the field, and the field is respiratory tract where the virus is known to like to live. And those are the two variables that we pay the most attention to in terms of deciding how we're going to care for these patients. For patients that have been positive 1 to 20 days, those are the ones that get the full bore treatment. They go into a negative flow operating room. They're intubated and extubated in a negative flow space. If we have to care for them, for instance, in the trauma room, which is not negative flow, then a HEPA filter is placed in the room. Those are the cases that we essentially double staff because we have providers outside of the room to make sure that supplies can be handed in and not contaminated unless they're needed. We have other providers outside to help with donning and doffing of PPE. Those are the ones we go full bore because those are the ones that are most likely to be highly contagious. Then the ones that are, in the 21 to 90 day group, we will wear N95 mask, face shield, gown, and gloves for the aerosol generating procedures, but not otherwise during the surgery. So if it's abdominal surgery, we'll wear an N95 and a face shield during the intubation. And then the rest of the OR crew comes in and they are in standard barrier mask and face shield without the impermeable gown and gloves and that stuff. So that approach is easier on the frontline staff. It still takes adequate concern for the risk of OR contamination and potential for OR team acquiring COVID, and is consistent with what the current guidelines are nationally.
Dr. Turner, you mentioned the changes that were constant with COVID policy and how often it might have changed on a day-to-day basis. And as a staff nurse going through all of this last year, we dealt with all of those changes. And it was frustrating for things to change, but really at the end of the day, we really just wanted to make sure we were doing the right thing and that we were taking care of our patients the best that we could. But as a leader for the OR, for all of perioperative services, it must have also been extremely stressful getting all of those changes as well. How did you disseminate all of that information or ensure that everybody was on the same page with the proper ways to implement the new protocols as they came out?
Yeah, that was very challenging because one of the things we did to try to minimize the number of changes we had to make is we would take draft workflows and draft policies and we would spread them out pretty widely so a lot of people had an opportunity to look at them and say, no, this isn't going to work in the interventional radiology area because of XYZ. Or, our national organization is saying that you should do this, so maybe we should include this in our workflow. So we spread the drafts out pretty widely, but the problem with spreading drafts out pretty widely is the drafts get out and people see them, and then that adds to the confusion because what comes out in your final version, with final lasting about 2 weeks or so, what comes out in your final version is likely substantially different from what was in the draft, which people have been reading and commenting on and thinking about and arguing over. So it really made things much more challenging. What we did really every time we came out with a final procedure that was expected to last for a few weeks, was we put it on our internal hospital website, which is called UConnect, and everybody in the institution has access to UConnect. And it would be labeled as things like COVID-19 surgical services workflow with a date. So everybody would know that was the final version as of October 24th, or that was the final version as of November 12th, whatever. And then every time we would finalize one and say, this is going to last for a while, we would also broadcast that across surgical services, saying, these are the current workflows, and this is where we're at right now. Yes, we know they're going to change in a few weeks, but this is where we are. This is the best place we can be at the moment. And then we posted those all over the operating rooms as well. So we've got a number of visual management boards in the operating room, and then we've got whiteboards in all of the operating rooms themselves. And we would post the current workflow every place we could find it, again with the date of revision prominently displayed so that people could see, nope, that one's 2 weeks out of date, throw that away. We need to get the new one. But it was still very challenging, and I have no doubt that our efforts to make sure that a lot of people had input into the workflows contributed substantially to the confusion that the frontline folks had over what those flippin' workflows were.
I know this is no epiphany, but what a challenge to leadership. And I know you have a great deal of leadership experience, but again, a very unique circumstance that you were under. How much did this challenge you personally, and how much did it grow your leadership skills or abilities through this process?
Oh, I think my leadership skills have kind of been beaten to death, and so they're kind of just the mushy pool at the foot of the desk right now.
I can only imagine, and here's the other thing. There's financial pressures too. I mean, you must have felt like you had it coming every which way. So I just have to commend you, because I can only imagine what an incredible challenge this was. Do you have any idea what the financial pressures were on the institution that were factoring into all that?
Oh, yes, absolutely. We went probably 6 weeks without our surgical volumes across the system. I'm pulling this out of thin air, but our surgical volumes across the system were on the order of 20 to 25% normal. And those were very much focused at University Hospital. And as I said, they were focused on life or limb surgeries. And it became apparent very early that the hospital could not survive that the uncertain support that we were going to get from the state and from the federal government was highly unlikely to make good on the losses that we were seeing from such a major reduction of surgical volume. And I want to add something else in, which was really just as critical, if not more critical to us. It became apparent very early that patients were not getting critical care that they needed. And this was because they weren't being seen in the clinics, because we had shut the clinics down. This was because they were being seen, in what clinics were operating or the ED or wherever, and they were being postponed. This was because patients weren't presenting for care. But it became very clear to us, and this is kind of anecdotal, but I firmly believe it anyway. Patients were being harmed because they weren't getting the care that they needed because of the severity of the drawdown. So it was not by any means just a question of the financial viability of the hospital. It was more so the core mission of the hospital was not being carried out. and that patients were suffering for it, and that patient outcomes were worse for it.
Yeah, it's almost intuitive, right? You're saying it's anecdotal, but you'd almost have to understand that care didn't stop because of one challenge that was presented to the healthcare industry. And so there's going to be a consequence, robbing Peter to pay Paul, so to speak. Dr. Turner, I can't even imagine what that was like and what it continues to be like, but I can tell you that your insights today have been extremely valuable to our listening audience, and I can't tell you how grateful I am that you squeezed us in amongst a very busy schedule to talk to us about the challenges and the evolving challenges throughout the pandemic. So before we wrap, do you have any kind of closing thoughts that you'd like to share with the audience?
Yeah, I've got a couple of things that I think are worth spending a little bit of time on. One is that for me, what the last year has taught us is the critical nature of balancing both COVID care and essential non-COVID care against the regional and state conditions and against the capabilities of the institution. So, as I mentioned earlier, one of the huge differences between this fall and last spring is our ability to handle this in terms of testing, in terms of equipment, in terms of workflow, staff training. We are much more able now to balance critical care and COVID care than we were earlier because we're much better prepared and we have much better capabilities. Having said that, this ain't over. Wisconsin numbers are looking a bit better, and we're cautiously optimistic, but there are a number of areas in the country that are suffering as much as they did in the spring, and we could easily see a significant resurgence in the upper Midwest. So until the vaccine really takes hold, so probably 6 to 9 months from now, we're still going to need to be doing this drill of what's out there, what are going to be facing, what do we have internally, what care do we need to provide, and how are we going to strike the best balance. The other point, which I think is really important, was pointed out to me last week and kind of brought me up short, is a question. Is this a dress rehearsal for the big one? Okay, we've been lucky in a lot of respects in terms of COVID. It's contagious, but there are worse viruses. It has high morbidity and mortality, but there are worse viruses. It at least was from a known family with vaccine development already well underway. That's why the vaccine was developed so quickly, as they'd already done a lot of the preliminary work. But we could easily see a variant of another virus that will be much worse than this. And it's incumbent upon us to take the lessons that we've learned from this virus and use them to get ready for the next pandemic. So, I saw a real risk that we would be too optimistic at the end of this. So I figured I'd go Debbie Downer on you.
Yeah, that's a great point, because systemically, we've learned so many things from supply chain, supply and demand. Like, this isn't just isolated to one aspect of healthcare. This has had an impact on every single department in the hospital. And so hopefully, not only have we learned lessons, and hopefully it's not the trial run that you say, Dr. Turner, but it's not hard to imagine that it could be. Not only do I hope that we learn some lessons, but I hope that we have the right communication mechanisms in place for us to continue sharing what we learned in the years to come so that we're better prepared. Dr. Turner, thank you so much for joining us today. And you definitely gave us some food for thought as we closed out the interview. So thank you again.
Thank you. I appreciate the time.
That was Dr. Chris Turner, Director of Perioperative Services at UW Health. And Melanie, I got to be honest with you. When Dr. Turner dropped the bomb at the end, which just seems so incredibly obvious that this might be a dry run or a test run for something that could be an even bigger threat in the future. I don't know why, but that had never occurred to me yet. And maybe it's just we all have the blinders on of trying to get through the day-to-day of the present challenge.
Justin, I think you're right. I hadn't thought about it either. And I mean, we've been working with this pandemic for a year and over a year, and we just keep dealing with one thing after another. And I hadn't thought that far ahead. But what we have learned over the last year, all of the changes that we've seen and all of the ways that we've approached this and attacked it and moved on, it definitely leaves me hopeful that as 2021 moves forward and as things move forward, that we're prepared for whatever's going to come our way.
I really do love how Dr. Turner talked about that whole environment in the OR and trying to lead through what seemed to be constant changes and what required multiple perspectives to really develop the best possible policy. And so navigating that and landing on a process and policies that work for an entire institution and then communicating that is no small feat. So congratulations to Dr. Turner and the team at UW Health. That's going to do it for this week's show. And as a reminder, you can help support First Case by subscribing on iTunes, Stitcher, Google Play, and Spotify. We'd certainly appreciate a rating and a review because your feedback is important to the show. And on behalf of Melanie, Jeremy, and myself, thank you for listening to this episode of First Case.